Hi, welcome to this brief Million Hearts Learning Lab webinar on leveraging pharmacists to achieve better blood pressure control. My name is Adair Blyler, and I work at the Cedars-Sinai Smith Heart Institute's Hypertension Center of Excellence. Joining me is Nicole Therian, who works at the Center for Disease Control and Prevention in the Division for Heart Disease and Stroke Prevention. Nicole and I are both trained pharmacists working in both clinical and research settings to improve cardiovascular outcomes. Over the next few minutes, we will discuss different strategies to integrate pharmacists into care for all people with uncontrolled hypertension or high blood pressure.
Just a quick note that the findings and conclusion presented today are those of the presenters and do not necessarily represent the official position of the CDC.
It is perhaps useful to briefly review the evolution of pharmacy practice in the United States so that we can better understand where we have been and where we're going. Pharmacy's history in America can best be summarized as very slow but steady progress towards greater professional standing through changes in both pharmacy education and practice. Urich and Meggs describe it as having 4 distinct periods: the soda fountain era, the lick, stick, pour, and more era, the pharmaceutical care era, and the post-pharmaceutical care era, which we find ourselves in today. Prior to the 1920s, pharmacists were largely engaged in compounding activities, but by 1920, the pharmacy community experienced somewhat of an identity crisis when there was a shift towards pre-manufactured products being preferred over compounded products. While prescription dispensing remained an essential part of every pharmacy's identity, it became just one aspect of pharmacy's businesses, as community pharmacies sought to increase front-end commercial interest through the expansion of soda fountains and offering of other goods for purchase. The period from 1950 to 1970s was a pivotal time for American pharmacy. A new version of professionalism arose with the introduction of PharmD programs, which provided the training needed to provide robust patient care services and introduced the notion that pharmacists had an obligation to their patients, which extended beyond simple dispensing of products. The pharmaceutical care era brought rapid change with new requirements for medication counseling in the 1990s. Pharmacist immunizers also emerged in the 1990s, and by the early 2000s, we had MTM, or medication therapy management services. The post-pharmaceutical era brought full circle the transition from a focus on product to a focus on the patient. In this current era, pharmacists are pursuing residencies and additional clinical training with increasing frequency, readying them to provide patient care services not directly associated with medication dispensing.
So when we think about strategies to improve blood pressure control in the United States, why include pharmacists? Well, Adair described the evolution of pharmacy education and the introduction of postgraduate training has prepared pharmacists for a new role. Pharmacists are medication experts, accessible, and trusted. Since 2000, the Doctor of Pharmacy, or PharmD, has been the entry-level degree for U.S. pharmacists. Core competencies of the PharmD program include biomedical and pharmaceutical sciences, cultural and structural humility, person-centered care, health services and public health, and interprofessional collaboration. Pharmacists are licensed health professionals through state licensing boards. Licensing requirements include those for maintaining competency through continuing education. In addition to the pharmacy curriculum and continuing education requirements of licensure, some pharmacists pursue additional postgraduate training, such as residencies or fellowships, and may attain board certification for specialized care. 88.9% of the US population lives within a 5-mile driving distance of one of the over 61,000 community pharmacies in the US. We also know that patients, including Medicare beneficiaries and commercially insured people, visit a community pharmacy nearly twice as frequently as their primary care providers. Pharmacists are the third most highly trusted professionals behind nurses and medical doctors, as measured by an annual Gallup poll of Americans' ratings of honesty and ethics among professions. Surveys indicate that people are becoming increasingly comfortable with and interested in receiving healthcare services in community pharmacies and provided by pharmacists. There's strong evidence that leveraging pharmacists as part of the healthcare team can improve hypertension control and other cardiovascular disease-related health outcomes. There are several evidence-based strategies to engage pharmacists to improve blood pressure control and prevent and manage heart disease and stroke, including medication therapy management, tailored pharmacy-based interventions to improve medication adherence, and formally including pharmacists in team-based care models, including with collaborative drug therapy management and models in which the pharmacist makes therapeutic recommendations to the prescriber. There are a number of examples in the literature that cite the actions of pharmacists as having contributed to improved cardiovascular outcomes, many of which are included in evidence reviews like the two cited here from the Community Preventive Services Task Force and the CDC's Best Practices Guide for Heart Disease and Stroke Prevention. In the slides that follow, we will review a few of these strategies and specific examples of programs that engage pharmacists to improve blood pressure control in patients. The Division for Heart Disease and Stroke Prevention has completed a rigorous evaluation of the Michigan Medicine Hypertension Pharmacist Program. In this program, which is guided by the pharmacist patient care process, a framework that describes pharmacists' approach to patient care, patients with hypertension are referred to pharmacists who collect patient data, assess the patient's drug therapy for appropriateness, plan and implement an individualized medication and lifestyle plan, and monitor the effectiveness and adherence to the plan through collaborative drug therapy management facilitated by collaborative practice agreements. The health system also partnered with Meijer, a supercenter chain store with community pharmacies, to extend pharmacy services in locations that were convenient for patients. Meijer pharmacists participating in the program provide hypertension management services, including making medication titration recommendations to the referring physician for their approval. Through interviews with program leaders, pharmacists, and physicians, it was revealed that the program has increased availability of services to Michigan Medicine patients by extending care services at locations that are convenient for those patients. Additionally, including pharmacists as part of the care team allows patients to work directly with pharmacists on hypertension medication plans, which frees up primary care physician time so that they can accept new patients by transferring existing patients to be managed by a pharmacist. The program supported the achievement of quality measures and improved health outcomes. At 6 months, patients in the intervention group were more likely to have achieved blood pressure control than those in the comparison group. Similarly, on average, patients in the intervention group had significantly more days with their blood pressure at goal than those in the comparison group. We've shared the findings of this evaluation in this implementation guide.
The Los Angeles Barbershop blood pressure study was a cluster randomized trial conducted by Dr. Ron Victor at Cedars-Sinai Medical Center in Los Angeles, California. Its aim was to develop an effective and convenient intervention for Black men, which linked health promotion by barbers to drug therapy by pharmacists. In this study, Black male barbershop patrons with uncontrolled hypertension were randomized by Barbershop to either an intervention group in which barbers promoted follow-up with pharmacists or to a control group in which barbers promoted follow-up with primary care providers and advocated for lifestyle modifications, or usual care, if you will. In the intervention group, pharmacists met with patrons at least monthly in their own barbershops where they checked blood pressure, prescribed medication under collaborative practice agreement, monitored electrolytes at the point of care, and sent progress notes to the provider after each encounter. The figure on the right-hand side of the slide depicts the intervention model. Everything took place inside the barbershop, which is represented by the rectangles. The barbers promoted follow-up with pharmacists, and pharmacists met with participants by appointment to prescribe blood pressure medication. In essence, the patron or participant came to the barbershop to get both his hair and blood pressure cut. The novel part of this particular intervention is that it was pharmacist-led. In many randomized controlled trials involving pharmacists often make treatment recommendations to the overseeing physician, and the physician ultimately determines whether or not to move forward with those recommendations or write a prescription. In this case, the pharmacists were completely in the driver's seat. After the primary care provider signed the collaborative practice agreement, pharmacists had prescriptive authority and could write or call in prescriptions without having to go through the physician. The primary outcome of this study was the change in systolic blood pressure at 12 months. As you can see, the groups were well matched at baseline with a baseline blood pressure in the low to mid 150 systolic. After 12 months, blood pressure fell by almost 29 millimeters of mercury in the intervention group compared to just 7 millimeters of mercury in the control group. The large change in systolic blood pressure was accompanied by a similar fall in diastolic blood pressure, which favored the intervention group by almost 15 millimeters of mercury. And a goal blood pressure of less than 130/80 was attained by 68% of the intervention group compared to just 11% of the control group. This multifaceted intervention addressed multiple barriers to care, including disease state awareness, issues surrounding trust of the medical establishment, and of course, accessibility of care by making the barbershop a one-stop shop. The key takeaways here were that simple treatment algorithms and short follow-up intervals and persistence in adjusting therapy when blood pressure remains above goal are key to achieving goal blood pressure rates.
The BP-HOP studies was a pilot project conducted by Brigham and Women's Hospital in Boston with the aim of developing an entirely remote hypertension management program that would leverage algorithmic pathways, home blood pressure monitoring, and patient coaching. A clinical algorithm, which I'll show in a minute, was developed by a multidisciplinary working group and designed to be automated and adapted for application by what they called patient navigators, essentially lay healthcare workers, who were trained by nurse practitioners and pharmacists to handle the daily aspects of hypertension management with patients. Patients with uncontrolled hypertension were identified through provider referrals and electronic health record screening, aided by population health managers within the MGB health system. Patient navigators consented and enrolled patients by telephone and then mailed them a validated cellular or Bluetooth-enabled blood pressure device after educating them on home blood pressure monitoring and transmitting readings. Navigators were supervised by pharmacists and nurse practitioners, while a physician oversaw the entire program as medical director. Home BP readings were monitored and analyzed as weekly reports. BPs that cross preset safety thresholds were shared via alerts with clinicians. Here's the full algorithm. The established algorithm determined not only medication intensification, the medications to start, but also the approach to routine lab monitoring. Upon review of necessary clinical data, the pharmacist under collaborative practice agreement makes changes via electronic prescribing. I'll note that the titration frequency was also noted in the algorithm. Finally, a progress note was routed to the patient's corresponding primary care provider or referring physician, and the algorithm also notes when referrals to other healthcare team members is warranted. Of the 130 total enrolled patients, control was reached in 81% of it, defined as a blood pressure less than 135/85. 11 patients dropped out, and in most instances because of insufficient engagement. 3 had resistant hypertension and were referred to specialty care, but 116 remained in the program. Of those 116 who were engaged in the program and measured their BP at home, the number of participants achieving goal blood pressure actually increased to an impressive 91%. As you can see from the graph, systolic blood pressure fell from a baseline of 155 to 124 upon graduation from the program, and diastolic blood pressure fell similarly from a baseline of 92 to an average of 74. Of note, participants reached goal home blood pressure in an average of 7 weeks. Like the Barbershop study, this program enabled more frequent dose adjustments of medications than usual care. After each titration, patients waited 1 week for stabilization and then repeated a set of home blood pressure measurements for 1 week. Thus, the cycle of medication titrations occurred every 2 weeks. This rapid titration bypasses the inevitable therapeutic inertia that marks so much of traditional blood pressure care. It's also important to note that blood pressure control at the end of the study did not differ among most demographic subsets. And finally, Control was reached without a large increase in pill burden. The average number of medications from baseline to control increased from 1.3 to 1.7. This implies that much of the benefit in blood pressure was achieved through improved adherence and maximizing drug choice and doses. So choosing drugs with fewer side effects, using combination therapy when possible, and providing consistent education on the purpose and importance of medication adherence.
As you can see, there are a number of ways that pharmacists can be engaged to help improve blood pressure control in patients with uncontrolled hypertension. We'd now like you to pause and reflect on ways in which your organization could include pharmacists in your existing workflows and care pathways. What barriers exist to this? What questions do you have about pharmacists and pharmacists' scope of practice? We look forward to a lively discussion during our Q&A portion on May 17th. Thanks so much for listening. Bye now.